Thank you very much for the opportunity to present on this very important topic, current NET research, nuclear medicine clinical trials. In the next 15 to 20 minutes, I would like to firstly highlight some current evidence of peptide receptor radionuclide therapy, PRRT, in patients with NETs, and then to discuss some ongoing clinical trials, then touch on some future developments and some lead concepts to watch in this space. So now in 2024, as we all know, PRRT works by delivering radiation, targeting somatostatin receptors that are typically highly expressed on well-differentiated neuroendocrine tumors. So in 2024, the main radiopharmaceutical used for this purpose is lutetium labeled with dotaoctreotate. It is given as an injection, typically for 4 cycles given 8 weeks apart. Now basically, after the intravenous injection of lutetium dotaoctreotate, it circulates around the body, and the radiation preferentially concentrates on somatostatin receptor expressing neuroendocrine tumor cells, radiation causing direct damage to the neuroendocrine tumor. We know that lutetium dotaoctreotate therapy can be effective in many patients. This is an example of a patient who has multiple sites of disease affecting the bones, but after PRRT you can see a dramatic reduction of tumor burden on imaging, accompanied by significant reduction of pain and improvement of this patient's quality of life. It is certainly very encouraging to see that there is now increasing evidence showing that lutetium dotaoctreotate therapy is effective, and certainly there are more trial data coming through, also supporting that this treatment is superior to some other treatments as well. So it all started back in the 1990s, where it was first used in human. Subsequently, multiple institutional series have shown that this particular radiopharmaceutical can be very effective in disease of various grades, primary sites. It can reduce hormone secretory symptoms and also improve quality of life. 2017 was the publication of the Nesta-1 trial, which was really the first prospective study looking at the use of lutetium dotatate therapy and shown that it is superior. And this was treated in a group of patients with small intestinal NET, with a grade 1, grade 2 disease. This actually led on to fairly rapid FDA approval of lutetium dotatate therapy in America and also several countries in Europe. It is very encouraging to see that within the last 5 years that more evidence and data are coming through as well. The ocular random trial looked at patients with progressive pancreatic neuroendocrine tumor, showing that lutetium dotaoctreotate therapy is more superior compared to sunitinib. The control NET study reported the use of combination lutetium dotatate PRRT plus CAPTEM chemotherapy, showing that this combination is feasible and effective versus chemotherapy alone, particularly for patients with pancreatic neuroendocrine tumors. Now, more recently, the Nesta-2 study has been published, also showing that lutetium dotatate therapy is very effective for patients with gastroenteropancreatic NET of grade 2 to low grade 3, with a Ki-67 of 21 to 55%. So really encouraging to see all these results coming through. However, we do still have some additional questions. We know that lutetium dotatate therapy is effective, but number one, is lutetium dotatate therapy actually better than other treatments for different NET patient groups, given it is such a heterogeneous disease? The second important question to answer is, how can we further improve the effectiveness of PRRT? Because we know that many patients respond to this treatment, but not all patients. I think to answer these questions, we really need to have high-quality clinical trials. It is very encouraging to see that currently there are more than 35 PRRT clinical studies that are registered in clinicaltrials.gov that are active and recruiting. So it is a really dynamic space, and hopefully we will get some answers for these questions in the near future. So in regards to the ongoing current clinical trials in 2024, to answer the first question, is lutetium dotatate therapy better than other treatments? Now, there are actually several ongoing prospective trials comparing PRRT to other treatments. Now, these are big trials and very important trials because the results of these may actually guide future practice. There are 2 phase 2 studies. The COMPARE-NET study is looking at lutetium dotaoctreotate therapy, comparing it to CAPTEM chemotherapy for patients with pancreatic NET. The NET retreat study is comparing lutetium dotatate used in the retreatment setting versus everolimus in patients with midgut neuroendocrine tumors. There are 2 phase 3 studies that are ongoing. These are big studies. The COMPOSE study is a very important one, comparing lutetium edotrietide versus best standard of care for patients with high-grade tumors, so grade 2 and grade 3 gastroenteropancreatic NETs. The COMPETE study compared lutetium edotrietide versus everolimus. Now, this particular trial has actually completed patient recruitment, but is in the ongoing follow-up phase at present. So I think it is going to be very important to await for the results of these big, potentially practice-changing trials. Now, the second important question to ask is how can we further improve the effectiveness of PRRT? Now, there are 5 main broad categories to consider. Number 1 is by doing combination treatment trials. So essentially in this particular category, we're trying to combine PRRT with another active agent to try to enhance the efficacy or sensitivity to radiation from PRRT. So there are 4 main approaches. Approach A, which is top left-hand corner, is to improve the perfusion or blood flow to the tumors so more PRRT can get to it. There are certain drugs that may be able to do this, such as temozolomide, sunitinib, or everolimus. Potential mechanism number B, which is on the top right-hand corner, is to upregulate the somatostatin receptor expression so that to increase the binding of PRRT to the tumor cells. And potential options is to combine PRRT with a somatostatin analog or epigenetic modulation such as an HDAC inhibitor. The third potential mechanism in terms of enhancing the efficacy is to co-administer PRRT with another DNA damaging agent such as chemotherapy or anti-cancer drug to increase the proportion of cell kill. Mechanism number 4, which is D, we can potentially combine PRRT with another targeted therapy that works in a specific pathway, such as combining PRRT with a PARP inhibitor, which acts to block DNA repair, or in other words, it enhances cell death. It is really encouraging actually to see that currently in 2024, that there are actually a number of combination treatment trials combining PRRT with a number of the agents that we have mentioned before. But really just wanting to highlight that combination treatment trials must be done very carefully in a controlled prospective trial setting because we really need to assess that this combined approach is safe and effective for patients with NET. Now, the second strategy to further improve the efficacy of PRRT is to use a new radionuclide other than lutetium-177. So this audience will know that currently the most commonly used radiation is lutetium-177. It actually gives off beta radiation emission over several millimeters. So it is actually very effective in terms of cross-irradiation of a single cell and also causing DNA damage as well. There is another type of radionuclide that gives off alpha emissions. Now, alpha emissions, on the other hand, actually emits really high energy levels over a very, very short distance. So proportionately can actually potentially achieve even higher cell kill compared to lutetium-177. A third type of radionuclide emits Auger electrons. Auger electrons, on the other hand, emits energy level that is actually relatively weak, but it concentrates in a very, very short distance. So it tends to concentrate mainly in the nucleus of the cell. So potentially, it can be very helpful and useful in terms of treating patients with very small or microscopic disease. So if you refer to the table on the right-hand side, you can see that lutetium-177, which is a beta emitter, is the most commonly used clinical agent at the moment. Copper-67 is a potential new radionuclide, but it has physical properties being very similar to lutetium-177, also being a beta emitter. On the other hand, terbium-161 is an interesting radionuclide because it actually emits both beta as well as Auger electrons. So it may be very helpful in terms of treating patients with heterogeneous disease with microscopic deposits. Now, the last category, which include bismuth, actinium, and lead-212, actually gives off alpha emissions. Now, as mentioned, very high energy deposited over a very short tissue range, potentially achieving much higher cell kill. And of most clinical interest at the moment is of actinium-225 and lead-212. It is really encouraging actually to see that currently there are several prospective clinical trials using these new radionuclides. So there's one ongoing study looking at terbium-161 labeled PRRT. There are 2 clinical studies looking into the use of lead-212 labeled with PRRT, so an alpha emitter, and 1 trial using actinium-225 labeled with PRRT. So again, we await with interest for the results of these interesting trials. Now, so we've talked about combination treatment trials as well as the use of new radionuclide to further improve the efficacy of PRRT. Now, there are several other concepts to consider as well, such as using a more personalized approach versus a one-size-fits-all approach. So there are clinical trials looking into, for example, administering PRRT via a different administration route according to the location of tumor, such as intraarterial versus intravenous. The use of dosimetry to help us better calculate with more precision how much radiation to give, and also the use of dual tracer imaging to help personalizing the therapy as well. There are several new concepts with PRRT, such as the use of lutetium dodeoxyritate in the retreatment setting, how to use PRRT together with surgery, the use and exploration of biomarkers such as ctDNA and imaging to guide PRRT administrations. And also, albumin binding is an interesting concept, which is to alter the chemical of the actual PRRT structure, chemical structure, to make it longer lasting and potentially more effective for patients. Finally, somatostatin receptors can also be expressed in other tumors as well, in addition to gastroenteropancreatic NET, such as pheochromocytoma paraganglioma. Certain small cell lung cancers may express somatostatin receptors, and also Merkel cell carcinoma. So PRRT may actually play a potential role in the treatment for these other malignancies. So what do we expect to see in the future? I think some interesting concepts to watch will include the development and finding new targets in addition to somatostatin receptors for NET. And also to mention that not all neuroendocrine tumors express somatostatin receptors as well. So an interesting target to look out for is CCK2 receptors or cholecystokinin 2 receptors. These may be expressed on neuroendocrine tumors, particularly for those that are SSTR2 negative and for medullary thyroid cancer. GLP-1 receptor can also be expressed in patients with benign insulinoma. CXCR4 may be expressed in patients with neuroendocrine carcinoma, so the poorly differentiated tumors. FAP, which stands for fibroblast activation protein, is a hot topic at the moment. Basically, it is expressed in fibrotic tissues, which may be very relevant for neuroendocrine tumors because of the desmoplastic reaction and mesenteric fibrosis, for example. So here is an example showing the potential benefit of CCK2 receptor imaging. So this patient has atypical lung neuroendocrine tumors with biopsy-proven multiple liver metastatic disease. You can see on the image on the left-hand side, labeled gallium dotatate PET-CT, that none of the liver lesions were actually very visible on this particular image, indicating that the lesions are not really expressing somatostatin receptors very much. But if you look at the picture on the right-hand side, with the gallium DOTA CPO4 imaging, you can see multiple liver lesions lighting up on this image, indicating that these tumors are expressing CCK2 receptors. Now, we know that CCK2 receptor expression can be seen in patients with medullary thyroid cancer, but also in some patients with NET that are SSTR negative. The interesting concept about this is that it could also be labeled therapeutically with lutetium-177 and potentially therapeutically treating these tumors as well. So prospective data is warranted and definitely expected in this space. Here is an example showing you the benefit of GLP-1 receptor imaging for a patient with benign insulinoma. So this is a 54-year-old female who presented with very high insulin levels and a very low glucose, so kept getting hypoglycemic episodes, which was very, very difficult to manage. Nothing was actually detected based on conventional imaging at all. So you can see on this particular image that the two jelly bean looking dark structures are the normal kidneys, but there is a focus of very, very intense uptake in the mid-abdomen. Now that localized to a very, very tiny lesion, at the region of the pancreatic head. With this knowledge, further investigations were done and the patient went on to surgery, and the surgeons actually were able to find and resected a very, very small lesion which was proven to be a benign insulinoma. Post-surgically, the patient was very, very well, and all her symptoms of hypoglycemia basically resolved after surgical resection. So in this particular slide, I also wanted to highlight that globally, including in Australia, that there are also prospective NET imaging trials being performed as well. So in the Australian local setting, we have the DISCO trial, which is looking at PET imaging with a radiotracer called copper-sartate for somatostatin receptor expressing NET. The Bayonet study is looking at the influence of long-acting somatostatin analog on the bowel distribution on gallium dotatate PET-CT images. The Donut study looked at another radiotracer investigating hypoxia in NET metastases. So to conclude, I think 2024 and beyond is really looking very bright. There are certainly an increasing number of prospective PRRT and imaging trials. Hopefully this will provide us with very robust data and evidence. I think the future focus really should be on performing more multi-center collaborative studies, particularly important for uncommon complex cancers like neuroendocrine tumors. There are also many new potential developments underway as well. The goals are to improve the clinical outcomes in patients with NETs and other somatostatin receptor positive malignancies. Performing clinical trials are very, very important because we need to provide the evidence to enable support and reimbursements for NET imaging and treatment for patients. So with that, I thank you very much for your kind attention. Thank you.